Thank you very much, Iona. And thank you very much, dear audience, for still being around here this late in the afternoon on the final day of our conference. I've had a pretty good conference so far. Have you?
Yes.
Great. Unfortunately, I'm not going to give you any kind of earth-shaking presentation that some of you maybe were hoping for as a grand closure of this conference, because I'm but a mere simple GP from Iceland, but I'm not a big hotshot like most of the keynote speakers. But I'm hoping to be able to keep at least 80% of the audience still awake at the end of my talk. Now, in Iceland, we have some fierce blizzards and avalanches and earthquakes and volcanic eruptions, but fortunately, no tsunamis. So it was quite a challenge for me being given this title, the tsunami of overdiagnosis in cardiovascular risk in general practice. However, I've been working in general practice in Gothenburg now for some 6 years, and I have some insight to the matter. And I have my academic affiliation in Trondheim, Norway, where I defended my PhD thesis a few years ago, and it was about cardiovascular risk and prevention, but mostly guidelines and their validity to general practice. You know, during my PhD studies, at some point of time, I realized that me, as a junior researcher, I seem to know the evidence base for about the risk factors and the preventive interventions, at least as well, and sometimes even better than most of the experts and the cardiologists I was faced with. And now I'm no more special than anybody here in this room, but neither were the experts. They were only human, and that was a real eye-opener for me. Which brings me to probably the most important thing I want to say today. Namely, my advice to you is to doubt. To always have a critical mind when it comes to guidelines, to clinical recommendations and to statements, especially when people indicate that they are presenting the one and only truth. They may be wrong, and they may only be presenting one aspect of the truth. So doubt, ask for the evidence, and ask for the counter-arguments, even if it makes you feel like I've felt so many times, like standing alone on the beach, just facing the big wave approaching. Now, I've heard it's a good rule to declare your conflict of interest, and I have to admit I have had my travel expenses paid by a drug company once, and that was to have a talk in Iceland about why we should not be lowering blood pressure cutoffs. And yeah, some pants and lunches I've received. I am a member of the Council for Sustainable Diagnostics and Treatment within the Swedish College of General Practice, an overdiagnosis council in my take. And I'm a member of the Nordic Risk Group, a network of GPs meeting and discussing medical risk and medicalization. And I try to have a critical mind. And to be able to be critical, you have to know something about the facts, the evidence, and the history. And as probably most of all of you know, we had early last century a huge increase in mortality from coronary heart disease in the Western world, mainly among men, with a steep decrease around 1970. And this is sooner to a larger extent and can be explained by medical intervention. Now, it was no wonder that the interest in the field increased dramatically, giving us studies like Framingham with important insights to in the risk factors. At the time, we didn't really treat high blood pressure, not unless it was malignant hypertension with systolic pressure far above 200. But it became a lot easier around 1960 with thiazides and beta blocker, which didn't have as serious side effects as previous drugs. Now, in 1964, there was a really interesting study published in The Lancet. It was an RCT on blood pressure lowering treatment in primary prevention. sky-high blood pressure at baseline and dramatic effects. But the most important thing, perhaps, about this paper was the introduction of a new idea, the idea of the potentially lifelong preventive medical treatment for healthy individuals. Now, this is a lot of what I'm doing in my work every day. This is where it began. We've seen some different cutoffs for defining hypertension, whom to treat. Most of us best familiar with this one. In the 90s, we got the statins and the combined risk estimates, and we began to move a bit away from focusing on individual risk factors towards overall risk. And the exact cutoffs began to fade a little, opening for the discussion on things like pre-hypertension and risk factor screening among children. Now, I'm not quite sure where this stands in the US today, and frankly, I'm not sure I want to know. But this puts the thing with lifelong treatment into a totally new perspective. In November, in the US, a new definition of hypertension. So my point here being, there is a clear ongoing trend for more than half a century always at the same aim, lowering and lowering and lowering the cutoffs, inevitably defining larger and larger and larger proportion of the population at risk and in need of treatment. The next step, as we heard yesterday, might be the precision medicine, which might effectively define all of us at high risk, or at least pre-risk or pre-death or something. Now, you've had a tsunami in the sales of preventive medication. Here are the statins in Norway and in Denmark. This is the whole Danish nation, and as you can see, by year 2010, a third of every 65 to 84-year-old was receiving statin treatment. That's a considerable proportion. Is it too much? Is it too little? Is it perfect, perhaps? I don't know. But me and my research team, we were interested in studying, looking at the risk profile of populations. And we studied the Norwegians, because they're interesting and lovable. And according to the guidelines at the time, almost 85% of the whole normal Norwegian population would be defined as increased risk, in need of increased follow-up and attention, and perhaps even medical treatment. Now, I know what you're thinking when you're seeing this figure. You're thinking, wow, the Norwegians sure must be sick. Do they realize this? Is the government taking actions? And in fact, no, I don't think they do, because they should be dying, not more often, but the mortality should be rising. But if you look at the lists of nations and their life expectancies, the Norwegians are still clinging on there near the top. So I don't think they realized the seriousness of the danger. But when I'm seeing this figure, I'm thinking, what does this mean for the primary care? What does this mean for the GPs? How many visits per year will this generate to the doctor? I'm thinking about the whole workplace. And we studied, at the time, the most recent European guidelines on blood pressure management. And if you follow these, you will need 99 GPs to take care of blood pressure follow-up and treatment for 100,000 adult Norwegians. At the same time, you only had 87 GPs in the whole study area. So either there is a cardiovascular catastrophe on the rise, or there must be something fundamentally flawed with these guidelines. And I think that is the case. It's not just these guidelines, it's not just cardiovascular guidelines, it's a rather general problem that guideline authors tend not to adequately estimate the workload associated with the recommendations, and the resources needed to follow the recommendations. And if your recommendations apply to a third, a half, or 85% of the total population, then it's a sign of some serious irresponsibility not to address the resource question, and perhaps even things like opportunity costs and such. And cardiovascular disease is the most common cause of death. So we are all at risk, and our children are at rather high risk of developing cardiovascular disease during their lifetime. So the potential market is everybody, and this is why we can talk about a tsunami in the cardiovascular risk. I'm going to talk about the American guidelines, and I'm not saying that these are any worse or better than other guidelines. It's a recent example, and I think a lot of this happens through the guidelines. So the most important new thing was a new definition of hypertension. And I just want to point out, you probably don't see the details of the flow chart, but even down to systolic pressure of 120, they're they're defining that as abnormal and recommending a rather intensive follow-up, I think, and therapy, non-pharmacological therapy, not lifestyle advice, therapy. And I can't see any sign of any attempt made to estimate the workload or the resources needed to follow these recommendations. And I find, I think the guidelines authors seem to have an interesting relationship with evidence-based medicine. One example, there's a recommendation on the follow-up of the patients. They're mentioning 1 month, 3 months, something like that. A strong recommendation. And they assess the quality of the evidence as BR. But that's moderate quality evidence from RCTs. So they're basically stating or indicating that they have RCTs, which indicate that it's better to see your patient in 1 month than in a year or half a year or whatever. And let's look at the evidence. This is what I could find 2 studies. And these are not the study results. These are the study protocols. And these studies, I cannot see that they have the follow-up as their research question. So in my mind, you basically could take any other RCT on blood pressure lowering treatment with a different follow-up scheme and put it as a reference here. So this should not be a BR, this should be an expert opinion. Sometimes that is just okay in what opinion. Okay, a minor detail perhaps. But I think if the guideline authors do not adequately label the level of the evidence, the quality of the evidence here, I'm having a really hard time to trust the recommendations. Not just these, but throughout the whole guidelines. This is the label of how strong trust we should have on the recommendations and the evidence behind these recommendations. So that's why I think it's a serious limitation. Now, according to the 130 cutoff, to my best knowledge, there are 28 RCTs on blood pressure lowering treatment with the mean systolic blood pressure at baseline lower than 140. So it's for answering the question, if you're already below 140, is there any effect from treatment? And there's a talented young Swedish researcher, Mattias Brunström, who has made some meta-analysis on this field, comparing different strata of blood pressure lowering. And in my opinion, these are the best meta-analyses available up to date. And his results are clear. There is no evidence of an effect of lowering blood pressure if you're already below 140. However, the guideline authors chose to use their own meta-analysis, made from including 5 randomized trials, and only 2 of these 28 trials. These 5 trials are treat-to-target trials, which are, of course, they're unblinded and known to be prone to bias. This kind of study tend to exaggerate the treatment effect. And throughout the guidelines, I think there is a disproportional weight put on the sprint trial. And the sprint trial has some serious limitation, and I think that you cannot really seriously make recommendations on changes in practice based on this trial. Unfortunately, I don't have the time to take this in detail, but I'm counting on getting a question afterwards from somebody in the audience. But I want to show you this meta-analysis from Brunström, which clearly shows how the sprint trial is a true outlier and not coherent with other studies in the field. The guideline authors estimate the prevalence of hypertension in the US by the new recommendations to be 46% of the total adult population. That's an increase of 14% of the total population, which is about 31 million new hypertension patients in the USA alone. And that's quite a big number for somebody coming from Iceland. Then Harlan Krumholtz and colleagues did a similar estimation in 45 to 75-year-old Americans, 63% having hypertension, 55% in need of treatment. And I think I'm hearing something. Might it be the sound of tsunami? So it's no wonder that the American GPs chose not to endorse the guidelines. Basically, the evidence does not support blood pressure lowering treatment below 140 millimeters mercury. At best, we might say the effect is uncertain, and in that case, minimal. But even that is reaching quite far for conclusions. And when the effect is minimal or uncertain, you really have to be sure that you're not doing more harm than good. And softer markers get an increased weight in the treatment decision. Now, soft markers. Is it harmful to get a label, to get a diagnosis, or be labeled at increased risk? What does it mean for a person when this is breakfast? Or even if it's just one pill, to be labeled as not well, incomplete, breakable. Various studies have addressed this question in different ways, coming to the conclusion that labeling alone can negatively affect the quality of life and even people's health behavior. Osteoporosis, hypertension, even false positive test results. And still, guidelines, pay-for-performance systems, policymakers put pressure on me in my work as a GP to follow the algorithms and focus on the details of risk reduction in cases where I know there are more important matters to be addressed that pose greater threat to this specific individual health and well-being. And I think what we are seeing with guidelines like these are heroic efforts of good intention to do the impossible, to eliminate all risks, to eliminate the complexity and uncertainty in medicine, to eliminate the complexity of life itself. And that is truly a mission impossible. I see it as my primary objective as a GP, to reach out and connect to people, to help people where they are towards better understanding, to help them to make the best choices available regarding their health and well-being. And I think that most people, at least all of my patients, they seem to have something going on in their lives threatening their existence and well-being more than a blood pressure of 130 to 80. I hope we can all agree on that. Thank you very much for your